morning, since it's sort of a confusing topic. I think difficult to get your mind around a little bit. What heterotaxy actually means is that it literally means something is in the wrong place. So heterotaxy is used to refer to the group of disorders where there is something located on the wrong side of the body. So these are generally disorders that are early in embryology related to the establishment of sidedness in the embryo. The most common things that kind of patterns that this falls into, it turns out the spleen is a very useful indicator of sidedness. The spleen is a uniquely left-sided structure. So whatever side of the body thinks it's the left side gets a spleen. So as whatever side of the body thinks it's the left side, because if you're an embryo, you're initially just a ball of cells, right? So you initially have no concept of left, right, or anterior, posterior, anything. So those all have to be established within the embryo, and the kind of cranial caudal is established first. But at some point, the embryo has to develop sidedness. So there has to be some sort of gradient of chemicals or something that establishes which side is the left side, which side is the right side. So if that system goes awry, it turns out the spleen is the left-sided organ. So these heterotaxies are often grouped into two broad classifications based on the spleen. If you have both sides thinking they are the left side, then you get what's called the polysplenia group of heterotaxy disorders, where you don't have multiple big normal-looking spleens, but you can have multiple what they call little splenules or spleens that can be on both sides of the body. Interestingly, most polysplenics have functioning spleen tissue, but some of them, although they're multiple spleens, have no actual functional spleen. Or if both sides of the body think they are the right side, then you get what's called the asplenia group of heterotaxy disorders, where there is no spleen, and those patients all have no splenic activity because they have no actual identifiable spleen. And then the other organs are a little bit variable, but the other organs to look at for sidedness, once you sort of establish which pattern they go into, the lungs will often follow the same sort of sidedness. So as you know, the left lung has 2 lobes with a lingula. The right lung has 3 true lobes. So they have different bronchial branching patterns. So if both sides think they're the left side, then you get what looks like 2 left lungs. So 2 bilobe lungs versus if they're so that's the polysplenia group, right? In the asplenia group, you get 2 right lungs, so you get 2 trilobar lungs, if you actually look at them pathologically. The heart is a little bit more complicated because the heart isn't just a sort of a left-right structure. It's actually a looped structure, so it's more complicated. So what happens in the heart, usually the atria go along with what we call the situs of the abdomen. So the abdomen, you have either situs solidus, which means normal situs of the abdomen, spleen on the left, liver on the right, stomach on the left. You can have inversus, where everything is exactly opposite that, or you have, most commonly in heterotaxy, you have what's called ambiguous, where you have either asplenia or polysplenia. You have a liver that's not totally right-sided, but it's sort of midline, and your stomach can be variable whether it's left or right. So when you have that ambiguous situation is when you get the complex cardiac conditions. That situs ambiguous is most commonly is where you get the really complex cardiac conditions. You can also get it with inversus. But with these ambiguous situses, you get the atria tend to go along with the abdomen. It turns out the atria are associated with the abdominal organs early in development. We think about the atria being on top, but when the heart tube is formed, the atria actually come from posterior, inferior, and then the heart tube forms and moves, and the atria end up sort of on top afterwards. So you can get, you usually end up with a AV canal type defect in the heart, often unbalanced, which means that you have a functionally univentricular heart, but can be balanced as well. So you often get this kind of large common atrium. And then the sidedness problems within the heart seem to be mostly associated with the veins. So the systemic veins the IVC is a kind of a uniquely right-sided abdominal structure. So again, if you go back to your asplenia, polysplenia, you try to figure out whether this is, both sides think they're the right side, both sides think that they're the left side. If you have the asplenia issue where you have both sides thinking the right side, then you normally have a normal intact IVC on the right. You usually don't end up with a second IVC on the left, but you have a normal intact IVC on the right. If you have a polysplenia situation, then the lower part of the IVC still forms up to the renals, but that hepatic segment is absent, and that's what's referred to as interrupted IVC. So in the case of an interrupted IVC, what happens is the femorals and the iliac still drain, as we said, up to the renals, but then the IVC just ends, does not go up to the heart from there. Usually what happens in that situation is that the IVC drains via the azygos or hemiazygos veins back over way posterior and up and into one of the SVCs. If it's azygos, it'll be the right. If it's hemiazygos, it'll be into the left. It dumps up into the SVC. So we see that quite commonly in these. The SVCs are variable as well. Many of these patients have bilateral SVCs, but there's no real hard and fast rule for the SVCs. So you really just have to figure out on a case-by-case basis whether they have one or two. Patients that have two often have no innominate or connecting vein between them. They often just have two and they both go down to the heart. And then the pulmonary veins are also kind of characteristically abnormal. So the pulmonary veins in the asplenia type, usually they don't find their way to the left atrium and they become totally anomalous. So we have the usual total anomalous pulmonary veins recur, and you can have connections through a variety of mechanisms. They can go in, as usual, they can go in for diaphragmatic, they can go into another part of the heart, or they can go out to the SVC. So the asplenics tend to have slightly worse cardiac disease because of that, because they'll tend to have the unbalanced AVSD can occur in both, but that in a combination with total anomalous pulmonary veins, where you have a true single ventricle and you have obstructed pulmonary veins, that can constitute a fairly bad prognosis for later in life, especially if you end up with lung disease or elevated pulmonary vascular resistance, and you want to someday be a Fontan candidate because you have a functionally single ventricle. The asplenic heterotaxies probably make the worst candidates for those. The polysplenic heterotaxies, they tend to have canals, but the pulmonary veins are usually not totally anomalous. The most common situation for those pulmonary veins is that the left ones go to the left-sided atrium and the right ones go to the right-sided atrium, so partial anomalous pulmonary atrium, where they couldn't really figure out what side to go to. Both atria thought they were left atria, right, because both the abdomen sides thought they were left abdomen sides, so this atria said, I'm a left atrium, so I got two pulmonary veins from over there, and this one said, I'm a left atrium, so I get two pulmonary veins from over there, and you end up with just partial, but usually unobstructed pulmonary veins. And then the ventricular morphology and great arterial relationships are also highly variable, difficult to predict. If you had to sort of think about it as a pattern, the most common thing you'd see in the heterotaxies is double outlet right ventricle with D, malposed great arteries, and some degree of pulmonary stenosis. So in addition to having canals and often pulmonary venous abnormalities, they often have fairly complex great artery outflow relationships with either pulmonary stenosis or pulmonary atresia. And so that suddenly puts you into a category, if you have severe pulmonary stenosis or pulmonary atresia, of being someone that requires prostents at birth to maintain a duct, and then some sort of neonatal surgery. Usually for these complex ones, if it's just an issue of complex disease with pulmonary stenosis or pulmonary atresia, it would be a shunt up front to provide for pulmonary blood flow, and then consideration of either repair or palliation later on. But some of the patients will have just garden variety transposition, or can have congenitally corrected transposition in rare situations. The situation where you have true inversus in all organs, where everything is just on the wrong side, there's a rare syndrome called Cartaginer syndrome, where it's truly a everything is on the wrong side. Those patients often have normal hearts. They're just dextrocardic with normal looking but completely mirrored hearts. And often the only abnormality that they seem to have is related to the cilia. Their body. So Cartaginer's has a similar ciliary dysmotility problem like as cystic fibrosis has. Where, and the theory is that somehow that sidedness generation has to do with ciliary function early on in embryology. So if that in that syndrome, if that doesn't form, it could be due to this sort of specific ciliary problem. So we have problems with pneumonias and pulmonary secretions and things like that. And then in the abdomen, the classic abnormality to look out for in the heterotaxis is malrotation. So the cecum, rather than being on the right side, is on the left, and sometimes upper as well. On the large intestine ends up on the wrong side of the abdomen, and that can lead to a higher risk of volvulus or obstruction. So often will be tacked down with the LADS procedure electively at the time that the patients are getting some other procedure, and that's usually kind of adjudicated on a case-by-case basis by pediatric surgery, but we have them look at all these patients for consideration. We'll do an upper GI to look at malrotation. If they're malrotated, we'll have them look at all the patients for consideration of the LADS procedure as well, because we think that that reduces the risk of having a later bowel obstruction. What else? Let's see. So a couple of other important points, I think. One is about the umbilical vein. This is confusing to fellows too. That if you have an interrupted IVC, so you have the lower segment but no segment up to the heart, the umbilical vein still leads normally to the heart. The umbilical vein does not actually drain into the IVC, but drains into the hepatics, right at the base of the heart. So the umbilical vein will follow a normal course. So even though you have interrupted IVC, so if you're in the cath lab and you put a catheter in the femoral vein and you start pushing it up, it'll start going up towards the heart, and then it'll turn, go way back towards the spine, up, around towards the SVC, and then come down to the heart. But if you catheterize the umbilical vein, it will go right up into the heart. So that ends up being a very useful route of access early on. It's important to, in those patients, to use the cath lab and get an umbilical line up in the heart early on if they're going to need lines and they're going to need prostons, things like that. The electrical situation in the heart is also a little bit variable. Basically, that's related to where the sinus node thinks it is, and where the sinus node thinks it is related to that sort of right SVC, right atrial junction. That's where the sinus node normally sits. So whatever part of the heart thinks it's the right SVC, right atrial junction, will be where the sinus node forms. So in some of these cases, that can actually be on the left, and in some cases it can be on the right. That's variable, so patients can have a normal P wave, or can have flipped P waves, or sort of a leftward P wave axis. It's variable, but most of them, the heterotaxis, as a group, there also seems to be a higher risk of congenital complete heart block, and so you can have a situation where you have this really severe structural disease and congenital complete heart block. And that combination has a very poor prognosis. The patients, as opposed to the patients with like maternal lupus or some other reason for having congenital complete heart block, who tend to do pretty well with pacemakers, that heterotaxy complex disease with congenital complete heart block has, I think, has a 5-year survival of like 10 or 20%. So it has a very poor prognosis when we see it.
Do you recommend transplant for those kids, or do you just recommend withdrawal?
The ones we've had, we've tried to treat them early with a pacemaker if they need it, and then see what they have. I think some of them have been transplanted, but they usually, if they do require an early pacemaker, that puts them into a category of generally poor prognosis. And I think transplant for these patients depends on their degree of extracardiac abnormality, because the transplant is very challenging in this situation, because the surgeon gets in, things are on the wrong side, so like the veins aren't even in the right place. So you're putting in a heart from someone who had veins and arteries that were in the right place into a body that has veins and arteries that are in the wrong place. So lots of strange maneuvering is required, I think, for the surgeon to actually even do a transplant in this situation. Other questions?
How much of this do you know in utero?